computer software keeps updating, so it looks different each time. Moral of the story, apex locators should work most of the time. It's not uncommon for a new associate to start doing endo and blame the apex locator, no different than the new associate loves to blame the lab for every time a crown doesn't fit, when they haven't necessarily worked out the 57 steps they did wrong, or one of the 57 steps they did wrong in the process of getting a crown, which is what I wanted to talk about today, is kind of walk through crowns from impressions to delivery and kind of hit some high points. But before we do that, Chad, did you want to go over that case? You want to save it for a private meeting? Am I putting you on the spot?
Can you hear me?
Yeah.
Yeah, I'd be happy to. Let me see if I can. Let's see here. What would be the best way to?
So you should be able to share your screen.
Yeah.
So I'm thinking we talked to about quarter past at most about the case.
Okay.
I did see your images, and I think we could probably talk about it for an hour, but
Yeah.
let's try to keep it limited because I made a little PowerPoint. I want to make sure we get through the whole thing.
No, for sure.
Was she doing core? These look like the core retractors, or were these just the retractors you chose?
No, so this was today at my other office up in Winthrop.
Okay.
And Kim, the owner, she's like, "Do you want me to just grab some retractors for class?" I was like, "Yeah, sure." And this is what she grabbed, so I have no idea. So yeah, this is a 59-year-old female. She came in wanting to do something about her discolored lower front tooth. You can notice that she has 3 lower incisors, not 4. She had ortho at some point in her lifetime, and they decided to extract a lower interior. So as far as the cause of why it looks the way it is, she said it chipped at some point a long time ago, and then they just kind of did some a little composite filling, which you can kind of see right. It's mostly the incisal, kind of towards the mesial as well. I guess, would that be mesial or distal? It depends on what tooth it is. And yeah, so she doesn't like how translucent and gray the incisal looks, but it also looks like even the apical portion of the tooth is slightly discolored as well. And didn't see anything crazy on the x-ray. I don't have the x-ray with me, but yeah, so she's looking for options. Talked about Invisalign with her, and potential expansion. You can kind of see everything is kind of crunched inward. And so she is setting up a consultation with an orthodontist, because I told her that for the best aesthetic outcome, putting all the teeth in the right place would be very helpful in that, no matter what we decide to do. And I told her that as far as replacing the composite with a better shade per se is not very predictable. I think whoever did this filling last time, they probably chose the correct shade. It's just a little bit thin on that incisal, so it's translucent and kind of appears gray. Then talked about a single veneer, but I told her I was like, doing a single front tooth is one of the most difficult things in dentistry. So then we talked about doing 3, but then I was like, then that still might not blend very well, so we might need to do 5. So there's just lots of options, and wanted to discuss that tonight.
Yeah, it's a great case. You know, when you show a case like this and you can see things like abfractions, recession, missing lower teeth, discolored teeth, open bite, you know, the tendency is to want to solve the patient's immediate concern, which, you know, obviously you're addressing, but I think your skill set's growing in the fact that you didn't just look at the tooth. You started to expand your focus a little bit into looking at the forest and not the trees. Let's talk quickly about the single tooth, and then we'll take a step back and look at the big picture. My initial, really, I'm just going to emphasize what you said, which is composite is a material not intended for perfection. And I say that fully well knowing that if you're an Instagram dentist follower, that there's dentists all around the world that can make some composite look like real teeth better than some ceramists do. So I understand that possibility is there, but in the everyday clinician's hands, that's very challenging. And the amount of time that it would take to make this tooth look like the adjacent teeth with composite might be counterproductive, especially in an insurance-driven practice or in a patient that doesn't necessarily want to pay, $700 or $800 for a resin veneer. So a good resin veneer in a fee-for-service practice runs about $700-800. So it's about half the price of a veneer or a crown, but it's double the price of a four-surface composite. Reason being, a four-surface composite fills a hole, restores the function of a tooth, whereas a resin veneer is an artistic modality that requires a skill set far above and beyond what the dental schools teach, and we should be compensated accordingly. With that said, I don't think most clinicians charge more than a four-surface restoration, but I think it's important that as we head into the era of consolidation, where our margins are going to start to get crunched, we should be cognizant of the procedures we do that take a lot more time than the CDT code had intended that to be. This is a great example of that. So can you do this with composite? Yes. Is it challenging? Yes. If you do it and do it well, should you be compensated a lot more than a four-surface restoration? I would say yes also. Knowing the layering techniques and the opacities of the materials and using characterization stains and lacquers over the top, that's above and beyond most skill sets of dentists in America, because normally they would just crown this tooth. That would be the easy way to solve this patient's problem. It's an aggressive option, maybe not something any of us want to do for this patient, but that would probably be the easiest way, because you're right, a veneer, what are the limitations of doing a veneer? And you started to talk a little bit about it. The color match.
Mm-hmm.
So a veneer being very thin, and a veneer relies on what? Enamel. So you only have a little bit of enamel here, so you can't reduce a whole lot. The more you reduce, the more dent you expose, the more you degrade the bond. You reach a point at which you can't reduce anymore. And what's the trade-off in that? It's a thin veneer.
Yeah.
And the underlying tooth structure can be compromised. So that's why something like internal bleaching granted this is not an endodontically treated tooth, but internal bleaching on a tooth like this before a veneer is a common advanced aesthetic procedure for an anterior tooth receiving a veneer. So always kind of keep that in the back of your mind. When you have dark teeth and you want to put a veneer on it, it's very challenging to block out that underlying tooth structure without some sort of auxiliary technique. There's opacers, there's zirconia you can bond now. Word on the street is I still don't believe that you can bond a veneer with the same level of flexural strength as Emax or feldspathic porcelain. But zirconia has more opacity, so you might be able to block that out. But that's challenging. So you presented this case because you knew it was challenging, and here we are talking, at length about how challenging solving this one problem is. Then you start saying, well, let's just add 2 veneers to increase the, to spread out the aesthetic challenge. And that is a technique, but I think if you're going to start doing that, this patient definitely needs a full workup. Mm-hmm. So, and I know you know this because you and I have talked about this. If you're going to solve this patient's problem with composite or a crown, tell her she's got other problems, but go ahead and do that. The moment she wants something more advanced, she's asking for a lens to take a closer look at things. So I love the fact you talked about expansion. This patient also needs a perio referral in addition to the ortho referral, but let them do that referral. One thing I want to make a point here. Anybody want to comment on what does clefting mean? Clefting is this little V-shaped notch in the gingiva adjacent to teeth. Anybody want to take a stab at what does that tell us? Has to do with the underlying bone. If we see clefting,
bone loss in that area.
Bone loss. So fenestration. So bone loss is correct. Fenestration is the specific classification of bone loss. When you see V-shaped notches in the periodontium, adjacent to teeth, you know there's very little bone there. As an orthodontist, I hope they know that. They should know that because it's a board question of theirs. But I have seen orthodontists move these teeth, and then all of a sudden you have a very large defect that has to be repaired. And I wouldn't want to be the periodontist that has to repair that after the orthodontist moves them, which is why sometimes it's good to send the patient to the periodontist first and have the periodontist refer to the orthodontist rather than the other way around. That way you know that the periodontist is in control of the case. Who did you refer to for the orthodontist?
It's Dr. Cook up in Augusta.
Yeah, I'm not familiar. I would imagine they're going to handle it well, but just it's good for us general dentists to know what happens behind the scenes.
Yeah.
And never assume that it's going to happen. You know, if this patient came to you and is looking for top-notch care and you refer to a less than ideal specialist, it does reflect on you. You know, our reputations are reflected upon the specialists that we refer to.
Yeah.
You know, fortunately, in Maine, I think we have top-notch specialists, at least in the Portland area. I can't speak about Augusta, but so that would be my recommendation. If she wants anything more than just an upgrade aesthetically, so either prep it back and do composite, because you definitely have to reduce it in order to create enough space to get some composite on there, or do a crown.
Yeah.
And
Can I ask like a tangent question?
Go ahead, Elena.
So I've never actually thought about doing this, and I don't know if this would work, but I'm just curious. She's got those black triangles on either side. If you did a little IPR and then brought the teeth in closer, is there any chance of improving that? Like, would you ever do that for someone? Have you ever? Does it work?
In theory, that would work beautifully. Anytime IPR works really well in that situation. That's probably the only time I personally do IPR. For those that are listening that don't know what IPR is an acronym for interproximal reduction. We use it in orthodontics and Invisalign to create space in between teeth where there's crowding or where we need arch length. In this case here, what she's saying is because of the black triangles, which is a periodontally compromising situation, if we remove the triangular nature to this tooth and then bring the teeth together, we bring the flat sides of the teeth together better and we actually close these spaces. So I love the idea. My initial thought is this patient's probably an airway patient. And and I say that because of her constricted maxilla, and she's got recession. So when you have a constricted maxilla and recession, what it means is the constriction of the maxilla is stressing the tongue and the jaw, and you're seeing through the recession and the V-shaped notching, you're seeing the body stress, and typically that's an airway issue. So I love the idea in a non-airway patient, and this would be a great time to get this patient assessed before anything. This is a great case where we take a full set of records, CAT scan, sleep study at home, get all of the data possible, and then start to unravel, okay, how do we solve this problem? And it's amazing. This patient started with a single tooth. Like, there is no more simple presentation for a patient that could result in a full mouth rehab. And I don't know how many people were in the email string that we had recently. It's never about full mouth rehabs. You know, I think one of the doctors made the comment that he was a little bit shy about the fact that he was doing a half mouth rehab. It's never about a full mouth rehab. It's about a full mouth rehab if the patient needs it. And I'm very proud of the team of people that we have to help kind of unravel these complicated cases so that we can treat the patients accordingly. But if truly the patient doesn't need a full mouth rehab, we're not doing a full mouth rehab. This patient needs a full mouth rehab. It just might not involve, 32 crowns. It might just involve, ortho expansion, perio, and, a really nice veneer and some internal bleaching, something like that. So I think the answer is you either treat the tooth with a four-surface composite, don't lose any sleep over the fact it's not perfect, or a crown. Don't lose any sleep if it's not perfect, although I think we could probably do a zirconia crown with some layering over the top of it to come out really nice. I have no doubt we could do that. Or you really start to get the patient on the comprehensive track, which it sounds like you did.
Yeah.
So I would just tell her that you want to wait on this tooth after the information comes in from the orthodontist. Now, I would make darn sure that she's seeing a periodontist before they start ortho.
Okay.
Great case.
Cool. Thanks.
All right. Anybody else have any thoughts about that before we switch over to crowns? All right. Is Labani here today? Well, he'll catch the recording. So on Saturday, his father was in, and we had the conversation about the two-chord technique. Dr. Greenbaum, you want to let me know if you can see my screen?
Yep. I mean, I see it.
I really do. I used to love New York.
Okay.
I hate it now.
Louis C.K., sorry about that. So what happens when I go to my screen is it blocks out the tab that I need to get to the... There we go. All right. Can you see that okay?
Yeah.
Two chords or not two chords? That is the question. Anytime we can spin off Shakespeare, why not? All right. Our goal today is hopefully to admit that we've never had an impression like the left side. But if we do, or we have any characteristics of this impression on the left side, that hopefully by the end of today, our impressions look more like the right side, and hopefully someday every impression looks more like the right side. With that said, I understand we're doing a lot of scanning now. All of these principles still hold true for scanning. One might say we don't need to create the same kind of margins for scanning. If you talk to labs, I've asked several labs this question. They say the more retraction, the better, regardless of whether you're scanning or not. So I don't want this to be an argument of whether or not we need to do two-chord techniques for scanning. When you do full mouth dentistry, you need to know how to do good PVS impressions. There's never going to be a day when we do everything digital. I take that back. That day is not happening anytime soon. We should learn how to do this well for the meantime. If that day comes, well, we'll still have an analog technique that we can fall back on when the power goes out. So this is a really nice diagram from Glidewell. Two-chord technique versus the one-chord technique is really what I wanted to focus the bulk of the presentation on. And this is a really good diagram showing the orientation and the size selection of two different chords when it comes to packing chord for teeth. I'd love to take a vote to see how many people do one versus two. I will say, if you ask most most prosthodontists, they're going to say they use the two-chord technique. If you ask most higher-end cosmetically driven dentists, they're going to use the two-chord technique. If you ask a dentist who's never actually thought through why 1 and 2 are important, they probably do one or none, or laser, electrosurgeon, what have you. And that's not a knock to people who do one-chord techniques. This is 100% from me asking many people over the past 15 years, what is your impression technique? And I can tell you there's a 100% trend between the quality of the dentist and whether they do one or two chord techniques. Okay, that's the goal of today. So this is an impression, very much focused to make the point that this is what an impression should look like. Whether it's a posterior tooth, anterior tooth, there is a very clear margin here with axial tooth structure. And that's one of the things we have to focus on. I noticed in dental school, where I went to dental school, they focused on this a lot. I'm not saying my dental school is better than yours, but when it came to impressions, they emphasized this more than other schools. Take it for what you want. Then I go to residency, and there's 7 different schools represented there, and there was quite a large varying emphasis on exactly what are we looking for when we look at an impression. Are you looking for the margin, or are you looking for information so the lab can make you a good crown that also includes the margin? And it's definitely the latter. This slide here is a little bit premature. We'll come back to it, but you want to have a perio probe handy. And my goal for everybody as they start to do more of this is to measure the axial height from the margin to the bottom of the sulcus. And the goal is 1 millimeter. it won't happen right away. Even if you're an expert in two chord techniques, there's a lot of variability in the outcomes of impressions with the two chord technique, but that should be the goal. That's kind of the, okay, if I'm going to be working towards something, what am I working towards? 1 millimeter circumferentially all the way around the tooth from the margin apically. So here we have one, which is the tooth margin itself. Number 2 is the axial root surface, or maybe not the root surface, but the portion of the tooth that is apical to the margin. For most subgingival margins, that will be the root surface. And then number 3 is the gap that's created when you do proper retraction with your chords. I pulled this off one of the Facebook groups I follow. There's dentists all around the world that post their beautiful work. This is amazing stuff. If you can get your impressions to look like this, you've done a good job. So what are the displacement techniques? So before we look at the two chord technique, let's talk about the other options. So the first is single chord with removal. That is typically a larger chord, size 0 or 1 or 2. You know, if you put it down in the sulcus, you might end up causing or inducing some bleeding. But the single chord technique with removal can be useful. I actually like it better than the one without removal in a periodontally stable patient. But then again, I don't like any single chord technique. But if I was to pick one, that would be it. The second technique, which is the most commonly chord-based technique out there, is the single chord technique without removal. And we'll come back to why I think that's inferior. Double chord technique, where you put in 2 chords, the smaller one then the bigger one, like we saw in that initial image, and then you remove the top chord just before the impression. We'll come back to that. Of course, there's tissue elimination techniques, electrosurge and laser. If you're going to do this, you have to answer the following questions. What is the patient's biologic width down to the 1/10 of a millimeter? What is the patient's gingival biotype? And will the patient sue you if they have recession into their bone and expose their root surface? So unless you can answer those questions, I'd be very careful about removing tissue. Reason being, keratinized tissue, you can remove that all day. But if you have inadequate keratinized tissue or insufficient keratinized tissue, thin biotypes, invasion of biologic width, and you try to use one of these 2 modalities, you're going to create something, and that's going to be a problem. Either bleeding, you may end up scarring the connective tissue layer, the lamina propria, where the nerves are located, we talked about a couple weeks ago. Patients may be very uncomfortable after the fact. So these tools are great in the right hands. I would say master the 2 chord technique before you start going down these roads. There are 100 conferences out there that will teach you that these are the easiest way to do the techniques. They're very much glossing, the people who give these presentations are glossing over the basic facts that they already understand all of the prerequisites for the patients that they're selecting, and they're assuming the crowd understands that. Well, if you're right out of school and you don't have a full command over biotypes, and then you start lasering everybody or electrosurging everybody, you're going to get problems. You may or may not notice it, but you're compromising the quality of the outcome. So there's more of a learning curve with those. And then lastly, chemical displacement or chemical treatment. There's products out there like Expasil. For those of you in the practice, yes, we use Expasil, or we actually use something called Access Edge, which is very similar. It's a aluminum chloride and kaolin clay compound. But we don't use it for the purpose of tissue displacement. We use it for hemostasis because it works really, really well for hemostasis under certain situations. But the product was initially sold as a replacement for cord. Traxident is also another product that's out there. I don't know if no cord PVS is still out there, but there was a PVS material that had an astringent in it that when you injected it into the sulcus, it expanded, and it had, I believe, ferric sulfate, which helped to reduce bleeding. I tried it for quite a while. I just couldn't get results. I've tried most everything. What do I end up doing? Falling back to the double chord technique. All right, so here's a very up-close picture of what the 2 chords should look like during the 2 chord technique. So the first chord should look something like this. It should be a smaller chord. Again, 00 or 000, the smallest chords possible. The goal isn't to displace the tissue horizontally yet. The goal of the first chord is to set the stage for the second chord so that you can come in with a 0, 1, or 2. The larger the number, the larger the diameter of the chord. If you choose too large of a chord for your first one, then you can't put a sufficient chord in the second one. You actually end up creating more of a problem than you intended. So choosing the chords correctly is part of the art of tissue displacement when it comes to impressions. Now, if you're doing a single chord technique and you choose a larger chord, you're going to get more displacement, but you're also going to end up potentially interfering with the margin. And the larger the chord gets, the more information on the axial root surface. Again, if you're a dental lab, you want to have that axial root surface. It's very important. The larger the chord, the more you cover and the more potential you actually remove the information for the lab in way of the margin. Anybody have any comments up to this point? Either everybody went home because they don't want to hear anything about the double chord technique, or I did a good job presenting it. A couple other things. I call this the impression capturing adjuncts. For those of you who follow Bill Strupp and Michael Brum on Facebook, they talk a lot about this 4% chlorhexidine routine. Amazing. I've done, they're the only ones that they sell 4% chlorhexidine. What they do is they have the patient come in 3 or 4 days before their crown appointments, and they have an assistant or a hygienist scrub this in with a scrub brush tip into the sulcus, remove the plaque, get the 4% chlorhexidine down in there to hopefully kill all the bacteria. When the patient comes back for the crown prep appointment and the impressions, their tissue literally looks like this. So we're going to be working on that. I haven't done 4%, I've done 2%, and I've been very happy with 2%. I can't imagine what's going to happen with 4%. Another tool that we can use is making sure that we schedule the patients somewhat after a cleaning. You can imagine if we're having a patient come in and they haven't seen the hygienist in 10 months or 12 months or even 5 months, their tissue is just going to be nastier. And anytime you have bleeding gums, you have to ask the question, what could you have done for this patient so they didn't show up on your doorstep with bleeding gums? We can blame them all day long. There's definitely things that we can do, and that's what this little slide is about, to help us in that regard. The easiest thing that I've done it for years, it's not the best, but it's definitely the easiest, is to have them pick up a bottle of Paradex a week or two ahead of time, and then I have them rinse 3 times a day with it for 30 seconds. Definitely makes a difference. And then lastly, what is the biologic width you're dealing with? When you're doing crowns on teeth, you kind of should know what the biologic width is. And I don't want to dive down this rabbit hole. There is a video on the YouTube channel that talks about biologic width calculation. If you don't have a full command on that concept and you're a restorative dentist, I highly recommend you do that. Stable crowns start with stable periodontia. And it's this concept that will help get you there. All right, so here's the 2-chord technique. Again, that first chord is smaller. The second chord is bigger. That first chord, its job is to vertically displace. Somebody just popped on. Vertically displace the tissue. All right, back to the slideshow. So again, the first chord brings the tissue down and it opens the sulcus for the second chord. Then you put in your larger second chord. Again, 00 or 000, 0, 1, or 2, or 3, depending on what you're doing. When you put that second chord in, it horizontally displaces the tissue so that your PVS impression material can fill this space right here. And it's that space that was number 3 in the photo that we looked at earlier. And it's the information that's gathered from a really robust amount of PBS material here that allows the lab to see the space right here. Why is that important? Well, let's just take a moment and all admit to ourselves that most of the time when we take impressions, we get this little bit of information right here. We say, oh, I can see the margin all the way around. I've done it for 15 years, so I know exactly what I'm talking about. It's very hard to do this. At the same time, I think it's necessary. I put this akin to the rubber dam. You know, once you get over the hurdle, you'll see the light on the other side of the tunnel, and you'll start to appreciate this more. But you can imagine if you're a lab and all you have is this little bit of information here, sometimes even less, how are you going to create an emergence profile that continues the root surface of the tooth? They're guessing. Yes, more experienced technicians can do a better job at that. But we know in today's labor market, most of the technicians we're dealing with aren't technicians in their basement that have been doing crowns for 40 years. They're somebody that was trained 2 weeks ago. They're not understanding this stuff. And I can tell you and I can promise you, even the good labs, when you send this inadequate information, they're just not going to fill in the gaps. You know, we as dentists think that when we send stuff to the labs that they're going to send back perfection. Even the best labs are not necessarily going to fulfill that every single time. Obviously, the better labs are better. But on average, if you don't send this information, you're going to get back inadequate results. So you might get a crown that starts here, but then it ends up going like this. We've all seen that where we take our Explorer after crown delivery and we're like, oh, wow, that's quite an aggressive profile. Now, that could be because we didn't reduce enough, so we end up having a margin that's inadequate, and the lab says, well, I need to put that material there because you didn't reduce enough for me. So that is one reason that happens. But another reason why it happens is they couldn't read the axial inclination of the root surface, so they end up guessing and they over-contour it. What happens when teeth that are restored with crowns have over-contours? The periodontium gets compromised. It's amazing how well the periodontal apparatus, all of the genetics that's located in this setup here, can sense when something's not right and then get compromised as a result. So here's the most commonly used chords. Every company might have a different numbering system. To be honest, this is the one I've been using for a long time. It works. There's definitely others out there. But UltraPack by Ultradent is sufficient for the use of chord packing. And here are the different sizes: 000, 00, single zero, so on and so forth. I use 000 to 1 99% of the time. I know lots of people who use 2, and that's great too. I don't feel like I need to retract that much. With that said, it makes great impressions. You may or may not have noticed they have these little scissor clips so that when you close it down, it cinches the cord, so you don't have to use scissors. So here is what I would consider perfectly retracted double chord technique. This is with the second chord in place. The goal of the first chord is to set the stage for the second chord. Now, what I see here is I can see the chord, so I can go out and get it. It goes up to the margin, but not over it. Therefore, this was a properly sized chord. If the chord is flowing over the top of the margin, odds are that it's not sufficiently compressed into the sulcus. So even though you choose a larger chord, you might not actually be choosing the right size because it's not going down far enough. When you're done, this is about what it should look like. Now, the first chord, you place one piece, not two. If the assistant gives you a small piece, you ask for another piece. You do not want to be stitching together 2 pieces of cord. Let's just say it makes for a mess. You should have one chord for the first one, and it should meet up like this. So they should be meeting butt to butt. To do that, you have to have the assistant give you a slightly larger piece of cord. You go all the way around, and then you cut where you need to, and you tuck in that last little piece so that the end and the beginnings are more or less touching each other face to face. The second one, you leave a tail. The best place to leave the tail is on the palatal. It doesn't have to be, but I just find that it's easiest to remove those when you're doing, especially full arch impressions, and you're trying to pull all these chords out at the same time. Have this cord running out the palette, leave enough that you can grab it, because you don't want to be chasing an explorer into the sulcus when you're taking an impression. Reason being, slows you down, but it also, you run the risk of actually getting to a point where you pull the other cord out. So here's an old photo. I just put this one up here. When you properly pack the cord, you actually get blanching. That's telling you you're displacing the tissue. You're going to see the blanching with the second cord, not necessarily the first. The second cord is the one that's actually doing the horizontal displacing for you, whether you're doing a digital impression or you're doing a PVS impression. That displacement is key for you to get that information that you need. So you should see a little bit of blanching. Blanching is not bad. You don't want to be forcing this in the sulcus. If you do it right, this is about what it's going to look like. And again, and I'm trying to repeat a lot here because I want to drive some points home. The first cord more or less disappears. The second cord you should see just like this, and it should stop just at the margin that you had prepared your tooth for. If you do everything right, this is what it looks like. Very thick margin or band of PVS where the impression material got to flow into. The thinner this is, the harder it is for the lab to guarantee that when they pour up the model, it doesn't displace. So when you see very thin layers of PVS here, you're opening the door for errors. It is a little bit better now that they're scanning impressions so that they remove that possibility. With that said, try to get some thickness of material down in there. Margin, axial wall, and thickness of material. One thing that helps, using these curved tips where you inject around the tooth, and you're putting the tip right into the sulcus. There is I think it was Dentsply had come out with a product. It was a PVS dispensing tip that was attached to the rheostat, and it had essentially pressure pushing the PVS material into the sulcus, and their whole selling point was that you didn't need cord, that the pressure was displacing the gum tissue. The problem with that is a lot of the reason why cord works is because you let it sit for a period of time and you let the gingiva actually drain of its hydraulic pressure. It actually pushes the fluid kind of out of the papilla. So that product didn't work because they were ignoring the fact that you can't immediately displace the fluid within the papilla and the gingiva. Therefore, double chord technique is still the gold standard, even though some fancy technology has come down the road. Another reason why I don't like buying technology that comes fresh off the line, because 5 years later it's typically not around anymore. Seen it happen time and time again. When you do this, I highly recommend using two hands. You should have either an assistant, the patient, both the patient and the assistant, or two assistants. You shouldn't be dealing with retraction and suction and all of that. Your focus is 100% on capturing this impression. You should be setting the stage for your patient so that when you're doing this, you have two hands on the gun so that you can inject this stuff without much of an issue to make sure that that tip is really right at the margin all the way around. All right, let me go back to here. Anybody have any questions up to this point?
Yeah, how long are you leaving that first chord? Like how long are you typically, like sometimes I'm just like, we're gonna suit you up for 6 minutes. Like I just make up a time, and
so the
I don't really
first chord
know.
or second chord, or both.
Well, the second chord, when the top chord, I should say, that when you get the top chord in before you pull it, how long do you need in reality for it to displace?
Yeah, 5 minutes is it's been studied. 5 minutes is enough. I will say more is better, but 5 is plenty.
Okay.
Yeah. I've gone to do hygiene exams where I got wrapped in for 20 minutes. I come back, I pull the cord, and it's like, oh wow, that's even better. But there's a law of diminishing return. You don't need to
Yeah, of course.
You don't need to have a gap a mile big, but 5 minutes when you choose the right chords is definitely sufficient. Yeah, great question, Jason.
I got a question.
Yeah, Chad.
Let's say the gingiva is kind of tighter on the buccal, but then kind of, I guess you could say looser on the lingual. So in terms of chord size, do you err on the side of like the smaller one or the larger one if you kind of have two different gingival?
Smaller.
Smaller.
Yeah, great question. I'll be honest, I bet that happens often, but I don't know if I've ever had that thought process. Now that you brought it up, I'm probably going to have a case in a month or so when I'm back in the chair, and I'm going to say, oh, that's a great question. But I would err on the side of smaller, and the reason for that is when you're trying to pack the cord, if it's too big, either it hurts the patient, you induce bleeding, or you just get frustrated because it doesn't stay in the sulcus. If you have a smaller one, it typically always works. I mean, you could do 2 000 chords and get a really nice impression. And that's really not that difficult to pack. I'm not advocating for that, but erring on the side of smaller is definitely better.
I got one. As far as, are you soaking these chords, or are you using some sort of viscostat or water?
Yeah, it's a great question. I mean, yes. I'll start with, you can buy them impregnated with epinephrine. I find that because the capillaries are so readily vascular in this area that the patients often feel the palpitations in their heart with it. So I don't think it's a bad idea, but to me, I want to control what caused them to bleed in the first place. So having them rinse with chlorhexidine, having them come to the office a week before to have a half hour, not even a half hour, a 5-minute cleaning on the tooth, and that might be counterproductive for a PPO-driven practice. But for full mouth stuff, it definitely pays off. So if we can reduce the need for an astringent, absolutely. But a very good technique is to soak the first chord. You can soak the second, but you don't necessarily need to do that. But you soak the first chord in viscostat, which is ferric sulfate, and then you pack that chord in. And that really does seem to do the trick. But to be honest, when you do the 2-chord technique, that first chord is keeping the bleeding at bay. It's when you do a single chord technique and you pull that chord, you're opening up a bloody mess most of the time. Under those conditions, I can't speak with a single chord technique whether soaking an astringent would help or not. But I can tell you with the 2-chord technique, that first chord soaked in viscostat is very helpful. Yeah, that's a good question, John. Yeah, but as far as impregnated chords go, the epinephrine one, it used to be very popular. It's less popular now. I think just from the standpoint that you don't want to induce palpitations in patients that are trying to relax and they're already nervous to begin with. All right, so here's a video from Glidewell. We can make fun of Glidewell all we want. I think over the past 5 years, they've improved their quality dramatically, but their website and their tutorials are second to none. So I pulled this off their website. This is Michael DiTola, who I don't think he works with them anymore, but he used to be their clinical spokesman. And this is a really good video on the 2-chord technique.
And look at all that space we have here. Now, as we look at this picture, let's backtrack a little bit. Let me remind you that if you remember from the prep module, the way the 2-chord technique takes place as it integrates with the reverse preparation technique.
All right, let's try. Thank you, Elena. Can you hear me?
And look at all that space we have here. You can see a wide space between the sulcus and the tooth structure itself. Sometimes you might even find a patient's car keys or a credit card they lost in there. We're looking deeply into the sulcus and seeing what we can see. Now, as we look at this picture, let's backtrack a little bit. And let me remind you that if you remember from the prep module,
somebody confirm.
The way the 2-chord technique takes place as it integrates with the reverse preparation technique is that I break the contacts first and foremost. So if we're prepping a central incisor or a lower molar, we break the contacts, and then I take a double 0 chord, so that the smallest one in the ultra pack chords, that double 0 chord, and we floss it into place, and then we pack it, we cut the two ends so that it's flush. So we have the double zero chord at the base of the sulcus, all the way down against the base of the sulcus. Now this accomplishes a couple of things. The first thing it accomplishes is vertical retraction of the tissue. So on a central incisor like this, when I put a double zero chord in, it retracts the tissue apically about a half to maybe 2/3 of a millimeter, just based on the patient's gingiva and how deep the sulcus is and the attached gingiva and all that kind of stuff. So somewhere between a half and 2/3 of a millimeter. Or if I do it on a lower molar, I put that double zero in and it retracts it again apically a half a millimeter to 2/3 of a millimeter. So this is useful, this vertical retraction, because when I retract the sulcus vertically, I'm going to be able to go in and prep at that free margin of the gingiva with my burr, with that round burr. And when I take that cord out, the tissue's going to rebound, and now we're going to have a restorative margin that's going to be a half to 2/3 of a millimeter subgingival. But I didn't even find a patient's car keys.
Sorry about that. I wanted to emphasize what he
and
just
now we're going to
said.
have a restorative margin.
So what he just said was, when you put the first chord in, either double zero or triple zero, and then you prepare to that margin, and then you put your second chord and take your impression, the resulting restorative margin will be subgingival, about 0.5 millimeters. So one might ask, how do you create invisible margins? That's it right there. You're not going to do that with electrosurge or a laser with any sort of predictability. Does everybody understand that? If they're going to take anything home away, when you need to bury margins, especially in the aesthetic zone, place your first chord, your double zero, your triple zero, prepare your margin to that gingival margin, and then finish the case. And what you'll be left with is a beautiful margin. That wasn't done here. Or that might be old and they had some recession, but everybody get that? Anybody want me to say it another way?
That's going to be a half to 2/3 of a millimeter subgingival, but I never had to take a burr subgingival, which would chew up the tissue, cause a lot of bleeding and stuff like that. So that initial chord does a good job of doing vertical retraction of the tissue, so I can now prep my margin at that gingival level, knowing it'll be subgingival when the chord's removed. The second thing it does is it acts as our Band-Aid. So we know the base of the sulcus is always inflamed on a patient. My teeth, it doesn't matter whose mouth it is. You put a single cord in there, leave it in there for a few minutes, take it out, there will be bleeding. It's just the way it is. So this bottom chord, our double zero chord, in addition to giving us vertical retraction, is also going to be our Band-Aid. So we can put another chord on top of it, the top chord in the two-chord technique, and we can pull that out when we're getting ready to make the impression, and now there won't be any bleeding because the double zero chord, our Band-Aid, is still in place. So that's the second important function. Won't be any bleeding. Sometimes you might even find a patient's card.
Damn it. All right, another point. The tool that you use to pack here, if the assistant hands you a very thin tool, you're going to get frustrated. If they hand you a plastic instrument that's too wide, you might also get frustrated. Play around with the tools that best fit your hands, but do know that too thin is very frustrating, too thick is frustrating. There's a sweet spot. To be honest, I think this picture actually does a pretty good job. That's actually perfect. The serrated ones I'm not a fan of, at least with the ultra-dent cord, because it picks it up sometimes. So really, just a plastic instrument that's a little bit wide seems to be, in my hands, what works. Just know there's many tools for each of our hands. You got to find the one that works best for you.
And we can pull that out when we're getting ready to make the impression, and now there won't be any bleeding because the double zero chord, our Band-Aid, is still in place. So that's the second important function of that double zero chord. I mentioned the double zero chord. The first chord gets rid of the vertical retraction. It takes care of it, and it takes care of most of it, and that's good, because once we've dealt with the vertical retraction, we can now try to achieve what we're really after, which is horizontal retraction. We want to move the gingiva horizontally away from the tooth. That's what laboratory technicians want and crave and need to be able to see, is that horizontal retraction. But the only way to get horizontal retraction with the retraction cord is to have already placed a cord in to get rid of the vertical one. Because if you didn't put that double zero in first, let's say you went right to the two chord and put it in, it still rolls under the gingival cuff and gives you gingival retraction, and it's under the gingival cuff. That band of gingiva that's here, and the cord rolls underneath it. It's not until we put our double zero in, and it's sitting there, we get the vertical retraction, and now we put a top chord in, The vertical retraction is already gone, where we now can get this lateral retraction of the tissue because it moves in 2 dimensions. So we have to move it down before we can move it out. The only other way to do it is if we had like maybe a size 12 or some huge retraction cord that would do both things at once. You can push it in, and assuming it didn't tear the tissue away from the underlying periosteum, you could get vertical and horizontal or lateral retraction of the tissue at the same time. That really doesn't happen very much so, as you know. This is the kind of impression that theoretically can lead to you having a crown that only has margins that are open 30 microns. I mentioned earlier that all crowns...
He was making that sound like it was a bad thing, and the picture kind of implied that it was a bad thing. That was actually a good picture with good retraction. 30 microns is the goal.
Are designed with 30 micron openings at the margin to allow the cement to escape when we have the patient bite down on the crown. And that's absolutely true, but they get worse from there. Depending on how difficult it is to read the impression, and therefore design the crown at the marginal area, and it can go up to 50 microns open, 100, 150, 200 microns open at the margin. So to really get as good of a margin as we can get, this is the kind of impression that we need to be sending to our laboratories. And it's not difficult to do. Is it more time? Yeah. 2 chords takes more time than no chords, as you might expect. But is it worth it? Well, it's incredible. You can't miss that impression. You're going to be taking a polyvinyl gun and squirting it in just like this. And look at all that space we have here. You can see a wide space between the sulcus and the tooth structure itself. Sometimes you might even find a patient's car keys or a credit card they lost. We're looking deeply into the sulcus and seeing what we can see.
Are you? Maybe some popcorn, who knows? All right. Anybody have any thoughts about Michael Dottola's little video there?
I do just about, the reason that there's an emphasis on this for an hour. And I think that, and I hope you might agree with this, that it's not to have us try and take, 3, 4, 5 impressions to make it perfect on every single patient. It's to teach us the principles behind doing it for a single crown, because I can speak from experience when, you translate this to a full mouth case, it's extremely difficult to ensure that, all of your margins look exceptional. And
yeah, I mean, the stakes are always higher with full mouth. I would say that, yes, this is more important than a full mouth, but you're just going to have more clinical predictability if you do this. You're going to have little to no retakes of your impressions. If you take one retake, you've already lost all of the time you thought you saved by not doing this. And there's so many things in dentistry like that, where we think we're cutting a corner to save time, and we think that we're not compromising clinical outcome. But the moment that it doesn't work the way we thought, we've lost all of our pretend time savings. This is 100% that time. You're not going to retake any impressions if you do this. You have good heme control. You're using the tip where you should. So it does increase the clinical outcome. But then again, this isn't to tell you guys to do 2 chord techniques, but I think you should have this in your toolbox, because there are cases, and Jordan, you and I talked about this recently. When you're down deep, you better know how to do this, because you're not going to get a single chord technique that displaces the tissue far enough to actually get a really good impression. Like most things, it's just another tool in the toolbox. But I just wanted to go down, because we're running out of time. We're going to pick back up on this next week, but I just want to show some inadequate impressions. This was decent reflection, but there was a bubble there. Definitely some pulls. We're going to talk about what leads to these things. I think today I just wanted to focus on the double chord technique as being another tool. This is what we send most of the time. I've seen all of our impressions, including my own. I've been to labs. I've literally gone to labs. I've done it 3 times in my career. And I said, can I just look at impressions? And they love that, because they want us to learn how to see what we should be sending them. Do that. Go to a local lab, say, can I just look at impressions? Can you tell me which ones you get frustrated with? Odds are they're going to look just like the ones that we do each and every day. I'm going to end there. We're going to pick back up. I have all kinds of stuff on crown retention, die spacer conversation, milling crowns, and why crowns are sloppy when we mill them, or more sloppy than cast crowns. But Bruins are playing, and I want to go watch the Bruins. Would anybody like to end with anything?
Go Bruins!
Yes. Soph, how is Zach feeling? Well, better, how are you feeling?
I'm feeling a lot better. Zach, I'm sure he'll be feeling better tomorrow, I think.
Since you're a patient, did I just violate a HIPAA rule since I announced that you were not feeling well?
Oh, no, don't worry.
I'm gonna suck it up.
Yes. Can I ask, if anybody changes their way of taking impressions and there's a positive benefit, please share it with me. My goal is not for me to change how everybody does things. It's for me to learn how to be a better teacher. So if I say something that moves the needle for you clinically, please just shoot me an email. I promise it'll make my day and it'll make me want to keep doing this. And there's Dr. Greenbaum with his little one. Hey, Lucy.
Just a quick hello. Hi.
Wow. Eyes are wide open.
Yeah, she's way alert.
Yeah. You know why? She heard the topic was double chord technique, and she was like, I want to listen.
She's like, this is coming into play.
Awesome.
Here we go.
All right, everybody have a good night. I'm getting my nose surgery tomorrow. This guy. So I'm going to breathe better than ever.
Good
Can't wait
luck.
to tell you all about it. And more about my toothache that's better, but we'll follow up with round 3 of that discussion. All right. Good night, everyone.
Good night.